Welcome to the Royal Berkshire Hospital and to your IT training for the use of the electronic patient record. My name is John Swinburne and I'm the Chief Clinical Information Officer and a cardiologist, and I'm the main link between clinicians and the IT team for developing the system. The purpose of this video is really just a brief introduction to some of the high-level clinical things we'd like you to do while you're working at the Royal Berkshire Hospital. The detail of how you do each individual bit you'll go through in your training. Many of you will be familiar with Cerner if you've worked at Oxford or Milton Keynes or elsewhere, and will just want to pick up some of the vagaries and differences of our system. And some of you who've never used it will obviously have a slightly more steep learning curve. But just to kick off, this is probably where you will spend most of your time when you're doing ward rounds. This is the doctor's work list, in this case, which is part of the board round view, which provides me with the doctor's work list, the whiteboard, and the discharge view. I'm going to go into an individual patient here, and I would recommend that you get into the habit of working from the clinician workflow view. If you right click on that, you can set it as your default view, so it will go to that every time. And you might want to play around with the components here and decide which ones you're going to regularly use and which ones you can get rid of. You'll go in through that in your training. One thing I would point out is that particularly on the ward, when you're using cows, the wide screens, it's really helpful if you can divide this into two windows here. So I'll just show you how to do that. If I come down to assessment, if you click this little box here, you can bring the assessment over to the other side, and I want assessment at the top and plan and requested actions underneath. So this allows me to have most of what I want available on one screen at the same time. So the most important field I think we have, which is still currently underused and which I would strongly encourage you to use to its full potential, is the hospital course field. You may find when you clerk people coming through from the emergency department that this is already full of data, because the emergency team will often enter their entire clerking into this field. And that's the purpose of that is so that it adds some continuity for you, so you know what's going on. You are more than welcome, and I would encourage you to delete that information from that field once you've ingested it, because what we would like you to do in here is to summarize what the key issues are with the patient, the key symptoms, key presentation, presumed diagnoses, and maybe any interventions and treatments that they've had over the course of their admission, particularly for a prolonged admission. The reason why that is so important is because this provides you an opportunity as an aid memoir for you when you come back to the ward round tomorrow, or when you're handing over to another team member next week when nobody on the ward round was here. Last week, no one knows who that patient is. It's crucially important when the hospital at night team come in tonight to look after this acutely deteriorating patient. They don't want to be spending ages wading through the notes. This should be a concise summary, usually of only several lines, detailing exactly what's going on with the patient, what you think the issues are, and what your current plan is. And furthermore, if this is regularly updated, it will make your life a whole lot easier, because this automatically populates into the discharge summary. So if you've done a good job now and ongoing, you will not have to add any further information to the discharge summary. That's the first field. The second field is the problem list. And I would encourage you as well to keep this updated. So this visit is the diagnosis at this for this admission. So this patient has appendicitis, and they may have a whole load of comorbidities. And if you enter all those here, you can use smart logic here, so you can type just a few characters from each word required. So if I go for polycythemia or something like that, I can get polycythemia rubra vera just from typing those characters. So chronic is a long-standing issue of past medical history. Acute is something that is relevant to this admission, and if the diabetes is going haywire and I want to make that relevant to this admission, I can do so by clicking the This Visit button, and the two appear. Similarly, if actually I got it wrong and the diabetes wasn't relevant long term, which clearly it probably is, I can remove that. And if the polycythemia rubra vera has resolved, I can resolve it and it will appear in the past medical history. It's often quite helpful to add in when patients have had procedures in the past, for example, and we often put in his history of stroke, but history of various procedures, which may be helpful in terms of your summarizing this patient's past history. And the other key thing here is that anything that is entered as a chronic problem will be visible on every admission. So when the patient comes in next time, if they have diabetes and a history of stroke and asthma and COPD, that will carry through next time, and you won't have to enter it again next time. It will save you time. It will also enter onto the discharge summary. So please get into the habit of doing that. The additional benefits are that it will improve our coding. It will improve the finance situation because we'll be coding all these patients properly. You'll be able to search patients by comorbidities, and I hope in the not too distant future we'll be able to produce you a report which may be useful for your logbook, which enables you to identify all the patients that you've been involved with, all the patients you've interacted with. And for example, if you're trying to do an assessment for your logbook and you want to prove that you've looked after 6 patients with alcohol withdrawal, you could, if you've been using this system, we should be able to produce you a report of the MRNs of the patients that you saw who had alcohol withdrawal, for example. The other point that you might want to consider is that you could use M-Modal Fluency Direct, this little icon here. We can give you a login for this if you are not a good typist and you want to be able to use voice recognition. Once you're logged in as this and you have a microphone, if you press the microphone button, you'll see that goes green, and I can now dictate into this field. This patient presented with abdominal pain of 5 days duration, full stop. A diagnosis of appendicitis was made and he was taken to theatre, full stop. An appendicectomy was performed, full stop. New line, plan, new line, discharge tomorrow. So for some people that may be very helpful, and we can also set up commands and things to help you automate some of the things that you do on a regular basis. If you want more information on that, please contact your IT support team. Once you've entered all the relevant data into these fields, it's absolutely crucial that you choose the right note type. You'll be shown how to set up default, so you only see a small number of note types, otherwise you'll be baffled by the vast number of possible options. Please make sure if it's just a SHO, house officer or registrar ward round, that you enter a ward round note. If there's a consultant on the ward round, or if you discussed it with a consultant, please make sure you enter it as a consultant ward round note, because this enables us to capture information for the 7-day target as to whether patients have recently seen a consultant in an appropriate time frame or not. And when I sign that document, it gives me an opportunity to decide whether that's the right note type, and I'm going to sign it as a cardiology consultant ward round note, or I might want to make it into, if I'm an SHO ward round, I might want it to be a clerking note, or simply a progress note if it's an SHO ward round. So please make sure you choose the right document type. Another key thing that will save you time in the long run is the entering of the medication history for patients when you're admitting them. Please don't just admit them, enter them in as free text. It will take you longer eventually. I suggest you go to Home Medications. If you go to Complete History here, and then Add, and you can add, it's very quick to add in agents. Most of them have got pre-completed sentences, so it's pretty quick and easy. Which I reckon is about as quick, if not quicker, than entering them in text. Document history, and there you can see the history of the drugs that the patient came in with. The reason this is crucial is A, it allows you to provide some structure to them, but more importantly, if you now decide that you're going to continue these medications, you're going to have to enter them anyway. You're going to have to enter those drugs in a structured way, and now we can simply decide we want to continue with the amlodipine. I have to put a weight in. Please just review that if it's still correct. Similarly with the allergies, you'll be able to review their weight and allergies on each admission. I'm going to stop the aspirin and I'm going to continue with tamsulosin. You'll go through the requirement for some of these fields as part of your prescribing training. But since you have to enter these drugs anyway, you might as well enter them properly. I've now done my prescriptions rather than having to enter them manually. And when I come to do the discharge process, again, it makes it much more straightforward because it's clear this icon is for drugs that the patient came in on. This icon is for the drugs that we prescribed in hospital. And if there's anything new, such as this, which just has been prescribed in hospital, it's very clear whether I'm going to give them some TTOs with those, or I'm going to stop them, or whatever. So please make sure you enter the medical agent history in a structured fashion. Just coming back to the doctor's work list, please remember the VT assessments. Lots of alerts will come up if you do them properly first time. They won't get in your face. Same with dementia assessment. We're having to streamline the VT assessment shortly, so hopefully it won't be such an inconvenience. And the final thing I wanted to flag up to you was the illness severity. This is the mechanism by which you will flag up patients who need review, particularly for the weekend. I'd encourage you to get into the habit of selecting this. So for most patients, it should be stable or discharging. If you want a patient to be seen by the team over the weekend, then the convention is that you should flag them on a Friday as unstable. Anybody on here as unstable will be reviewed at the weekend. You can also access that stable tab up here. You can go in and change it there. And similarly, quite a useful thing is to be able to, if you add actions here, speak to relatives. If I save that now, close that patient down, rather than having to scribble these things on a bit of paper. If I hover over here, there's my action to speak to the relatives. If I go back into the patient, I've now completed that action and I can tick it off. And this can be available when I enter it, available just for me so no one else ticks it off, or available to all the rest of the team so anyone can do it on my behalf. So there's a brief summary of some of the clinical processes. I hope it's been useful and I hope you enjoy the rest of your training.